It's my pleasure to introduce Dr. Caridad Ponce Martinez, who is the Director of Clinical Services in Addiction Psychiatry and an addiction psychiatrist at the Addiction and Comorbidity Treatment Service within the Outpatient Psychiatry Department, who will introduce today's speaker.
Good morning, everyone. I am honored to be introducing our speaker today. Dr. Richard Schottenfeld is a professor and chair of the Department of Psychiatry and Behavioral Sciences and director of the Center of Excellence on Behavioral Health at Howard University College of Medicine and Hospital. He's an experienced clinician, educator, and clinical researcher, and Dr. Schottenfeld has developed and evaluated innovative interventions and service delivery models addressing behavioral health and substance use disorder treatment needs and disparities. Prior to joining Howard at Yale Medical School and the APT Foundation, where he was a mentor of mine for an entire year, I was very fortunate to have that. He led academic and community-based substance use disorder treatment programs and clinical research and training programs. His work has helped expand treatment access and reduce stigma by integrating addictions treatment in primary care, HIV specialty, and other medical settings. Since 2017, when he joined the faculty at Howard, the College of Medicine and Hospital have greatly expanded behavioral health treatment services and clinical training. He started an addiction medicine fellowship training program, and in collaboration with the Community Advisory Board, initiated the Better Together Howard University Community Partnership, a NIDA-funded clinical trials network HEAL project. Dr. Schottenfeld is lead investigator on NIH HEAL NIDA CTN 0144, a multi-site study in the District of Columbia, Chicago, and Miami that is evaluating an integrated community collaborative model, care model for providing medication treatment for opioid use disorder in non-medical community settings to improve engagement and retention of Black persons with opioid use disorder in MOUD. Thank you, Dr. Schottenfeld, for being here.
Thank you, Dr. Caridad, for the warm introduction. And it's a pleasure to be here. And turn that down. Good to see Dr. Yonkers. We shared space and time at in our previous haunts. So I'm going to talk about some work addressing racial disparities in opioid overdose deaths and treatment. And as I'm looking at that slide, I'm beginning to love it because it feels like I'm a race car driver and I have all these sponsors, but we'll see. So I don't have any conflicts of interest to disclose, although I gather with your new COI form, I have to talk about all my grand rounds, but the work that I'm doing is supported by National Institute on Drug Abuse, the NIH HEAL initiative, and our Center of Excellence grants. So here's what I want to talk about. Opioid overdose deaths rates are skyrocketing in the US. We all know that. Medication treatments for opiate use disorder reduce those deaths and other risks of opiate use disorder, but they remain greatly underutilized. Overall, less than 25% of the people with opiate use disorder in the US receive medication treatment. We think we should be able to do better because if you look elsewhere in the European Union, their countries with 80% or higher, I think the average ranges from 60 to 80%. And then the skyrocketing overdose death rates and underutilization of medication treatments are much worse for Black people. And so our questions to address are, how can we increase coverage, meaning the number of people needing the treatment who are receiving it, for medication treatments in the United States? What accounts for the racial disparities? And how can we reduce those disparities? And what I'll do is I'll provide a pretty brief overview of the 4 waves of the overdose epidemic nationally, changing demographics, the persistent treatment gap, and then the efforts that have been done to reduce that gap. And then we'll try to do a deep dive looking at Washington, D.C. as a paradigmatic my home city now to address the problems in the district. So I think that people may have seen these 4 waves of the opiate epidemic, but we know the beginning in early 2000s, these are graphs of the numbers of people dying of opiates by by drug type. And we know that there was a huge increase that was fueled initially by prescription opiates, OxyContin, oxycodone, and that pretty much up until about 2011, thereabouts, when we started massive efforts to educate people, reduce overprescribing, and we've done a pretty good job at that. But unfortunately, the second wave came in about then as people started shifting to heroin. And so that second wave was heroin. And then the third wave is synthetic opioids, fentanyl, which started really coming in the 2014, 2015, and is accounting for a huge amount of the increased overdose deaths. And then even more recently, the combination with stimulants, psychostimulants, cocaine and methamphetamine. So it's increasingly those combinations that are accounting for these, for the deaths. As part of the changing dynamics, what had been initially seen as a problem in rural America has become a problem in urban America. And so here, just a number of different ways of looking at it. But by 2020, so 4 years ago, these are overdose death rates in America's biggest cities. The line in the middle is sort of the average across the country of about 20 deaths per 100,000. Now, what we see in the big cities, Baltimore, Cleveland, Columbus, Boston is down here. Washington, I think, is a little bit higher. There's Washington. Overdose death rates are much higher than national average. When you look at the demographic groups, what you see is pretty much with, say, white or non-Hispanic whites, overdose death rates are a little bit higher now in the cities than in rural areas. But among Black persons, overdose death rates are much, much higher in the cities and lower in rural settings. And the other part of the changing demographics was what had started off as white. Of course, people overlooked the American Indian, Native, Alaskan natives, which people weren't talking about during the epidemic, but it was extremely high. Among Black persons, up until about 2011, 2012, overdose death rates stayed pretty steady among Black persons, but since then have risen faster than any place in any other ethnic group, racial group. And by 2019, 2020, the overdose rates among Black persons exceeded the rates among white persons. And we'll come to, this, I'll spend more time talking about the lack of treatment. Okay, so now we know that medication treatment reduces overdose risks, but there's low uptake. So the most recent, 2019, only about 17% of the 2.2 million people in the US with opiate use disorder were receiving medication treatment. Those are people with active disorder estimates. And that problem is much worse for Black persons with opiate use disorder than for whites. And across different studies and populations, and I'll just give you 3. First one I think is useful from the state of Massachusetts, which is they look at all the people with opiate use disorder, pregnant women with opiate use disorder, and they're all covered, right, by insurance. This isn't an insurance issue. It's covered by Medicaid at a minimum. But a Black non-Hispanic pregnant woman with opiate use disorder is 37% less likely than a white pregnant woman to receive medications treatments. Following an opioid overdose nationally, Black patients are about half as likely as whites to receive follow-up medication treatments of any sort. Across 6 healthcare systems, Black patients were 30% less likely than white patients to receive medication treatments. And again, the differences persisted even after controlling for insurance status. And then this is Barnett's 2023 New England Journal of Medicine study that looks at these disparities. After hospitalization for index event, these are among Medicare beneficiaries, so nationwide sample of Medicare beneficiaries, hospitalized for an overdose, for an infection related to opiate use disorder. And they look at percentage of patients, white patients who receive medication treatment, or receive buprenorphine versus Black patients. The first thing is the overall percentage is pretty low, period, even for white persons. But if you're a Black person, it's even lower. And it's the same. It's not just medication treatments, but even naloxone prescriptions. And it's not only a difference in who starts, but how long people stay in treatment. So retention in treatment, you get all the benefits of medication treatment while people are taking it. So among, and what it's a complicated series of graphs. This is based on prescription data, pharmacy prescription data across the country. And it looks at median duration of buprenorphine treatment for white person versus Black person. Graph showed that the median duration was increasing for a while, but since 2014 has dropped off among Black persons. It's remained about the same among whites, or the percentage of people with durations of longer than half a year, 180 days. It's still lower than what it should be, 27% for whites, and less than 25% for Black persons. All right, so then what accounts for such low utilization of medication treatment overall? So for substance use disorders generally, National Survey on Drug Use and Health provides this interesting graph, interesting because it doesn't change much year to year to year to year. And it looks at all the people who are estimated to have a substance use disorder, what percent got treatment, and of all the people who didn't get treatment, so 18.9 million people needed but did not receive specialty substance use treatment. This is 2018 data. How come they didn't get it? 95% because they said, well, they didn't feel they needed it. A small number, small percentage tried and didn't get treatment. So these statistics can be used for people to say, well, there's nothing we can do about it, create great nihilism and hopelessness. And so the question that I've been asking for a while is really the field of dreams question. If we build it, will they come? Or is treatment demand inelastic? Meaning people are either interested or not interested in getting treatment. And certainly through the early part of the AIDS epidemic in the mid-'80s, there was a prevalent view that you're just not going to be able to reach drug-abusing populations with health messages. They're not interested. But our experience with the AIDS epidemic was that's not true. You can reach them. You have to figure out novel ways of engaging. And when you do, you can see big changes in behaviors. People shift from injecting to non-injecting routes of administration. They use clean needles. They made a lot of changes for health. So, the alternative is maybe we need to do more to attract and engage patients in treatment. So an early model that we looked at to be thinking about, well, does that work? Was just thinking about, well, what happened in Amsterdam when they set out a mobile van to provide methadone treatment? And they set up a series of stations across Amsterdam and provided a limited health care, and people could start medication treatment. That was methadone on the bus, and they didn't have to travel, and treatment was free. And I visited the bus, and all the staff were incredibly friendly and welcoming, and there was no stigmatizing behavior. And just this buses managed to get 60 to 70% of people who are using heroin in Amsterdam into treatment. So that really has, for me, opened up the thoughts about, so what do we need to do to bring people into treatment? And the first whole sets of strategies that I've been looking at, other people have been looking at and working on, is how do we broaden the base of treatment? And we can't just have it located in specialty medical settings, but how do we mainstream medication treatments into primary care settings, the emergency department? How do we open up the system? And so I'll talk a little bit about that, and then what happens when you facilitate getting people in quickly, and then move into what we've been doing, because it's good, makes a difference, it's still not enough. So in one of our early studies prior to buprenorphine getting approved for general use for medication treatment, we knew that it was likely, when it got approved, that it would be available outside of specialized narcotic treatment programs or methadone programs. And we looked at, well, how about doing it at a primary care clinic? And we did it, compared 3 levels of counseling. That's less important for right now. But the main finding of the study was that buprenorphine treatment was feasible and effective in the setting, and it didn't, it was implemented with all 3 counseling types. Even from that pretty early study, we started looking at, well, what do people think about the treatment there? And people liked it in general. No one knows why I'm here. I don't have to go to a methadone program. Everybody knows why somebody shows up at a methadone program every day. They either work there or they're a patient there. They know I don't work there. So if I go there, they're going to know who I am. We actually heard that from a teacher who came into this project in primary care, who'd been heroin dependent for about a decade and had avoided treatment because she said, I can't go to the methadone program because I will see the parents of my kids and they'll know that I'm addicted and I will lose my job and I will, but I can come here because I could be here for blood pressure. Treated like a patient, all the differences that were attractive. And even in that early, we just did a comparison of who was coming into the methadone program. We ran an extensive set of methadone programs in New Haven at that point, and we were running this study. And we looked and we said, well, actually this research study, the primary care, is bringing people who are a little different. They're younger. They haven't been been using opiates for as long. There were fewer who had started injection drug use. So we seem to be reaching people who weren't being reached by the traditional narcotic treatment program. Now, nationally, that's what we've seen since the introduction of buprenorphine. This graph looks at the early rollout of buprenorphine beginning in about 2003. It looks at sort of the total number of individuals estimated to have opiate use disorder, which unfortunately was going up all through that period. Looked at the numbers who were being treated with methadone, which stayed flat across those years, and then looked at the people numbers who were being treated with buprenorphine, and virtually all the increase in capacity and increase in utilization came from opening up buprenorphine in primary care, physician office settings. And there have been major national initiatives to expand buprenorphine treatment. In HRSA, had 12,000 sites of primary care sites made efforts. This is between 2016 and 2018. They trained a huge number of providers. It recruited, almost doubled the number of centers that were providing buprenorphine treatment, and across those expanded the reach. So we know that's helpful. We're getting partway there. There's a little thing, I think maybe Dr. Ponce was involved in the open access methadone clinics in New Haven. When we were running methadone programs, For the longest time, there were always waiting lists. Frankly, part of the reason why there were always waiting lists is when I went up to the state, or other people did, to advocate for more money for methadone treatment, they said, oh, nobody wants to come in. And they'd show me that graph that I started with, people who are, they're not interested in treatment. We figured out a different system. The first thing we did is we figured out, how can we get people in the same day? And so we moved from an average wait of about 21 days to less than a day. And what happened to the number of patients that we were treating in our methadone programs? As we shortened the waiting list and we made it easier for people to come in, we got more and more people to come in. So it's not totally inelastic. That's the good news. For me, the disappointing news is when I started, 2,500 was the estimate that my esteemed mentor gave me for how many people with opiate use disorder were in the New Haven area. And so this part of what attracted me to the small city is we could treat everybody. That's a discrete number. I can create a program that will do that. Well, we hit 4,000 and still counting. So we've increased capacity. I think what we're doing is, so one, the epidemic is increased, and two, we're hitting populations that were hidden. So I think that first answer is yes, if we build it right, they'll come. But there's still substantial underutilization. And the problems are much worse for Black persons with opiate use disorder than for whites. Now, part of the issue is that the expansion of buprenorphine has been targeted initially at white populations. So this was an early slide. This was just looking at the likelihood of a Black person to number of visits for Black persons with opiate use disorder getting buprenorphine treatment versus white persons. All the expansion was for white persons. It was also combined with insurance issues. Buprenorphine, a lot of that was self-pay, and people needed resources or the best of health insurance to be able to cover. And that interacts with race and ethnicity in bad ways. But the disparities in access also had to do with where buprenorphine was being provided and where methadone was being provided. So Helena Hansen, back now a decade ago, looked at that early rollout just in New York City and found that, well, buprenorphine treatment in New York City was concentrated in areas with the highest incomes and the highest percentage of white residents. And methadone programs were concentrated in the areas with the higher proportions of residents who are in poverty, Black and Hispanic. And, more recently, looking across the country at counties where methadone and buprenorphine, looking at the number of facilities or providers of methadone and buprenorphine and indexes of the concentration or the amount or the percentage of people who are white or Black in a county, they found this 1% decrease in the probability of interaction of a white resident with a Black resident, so whiter counties, was associated with 8 more buprenorphine providers per 100,000 population. And each 1% decrease in the probability of a Black person with a white resident, meaning more segregated and Black population, with more methadone facilities. So we've concentrated, methadone in urban settings and often in the poorest areas, and we concentrated buprenorphine prescriptions in white areas. And a couple of years back, when I went to look at, so what's on the websites, what's available on the web to promote buprenorphine treatment? These were the faces of recovery that I saw. At that point, I haven't looked recently, but at that point, I couldn't find any Black faces. And there was some evidence of a fairly deliberate marketing strategy early on of where buprenorphine was marketed to. Okay, so I promise we'll do the deep dive in the district. So here's the background. This is pretty much what I moved into in 2017, that at that point, overdose death rates had tripled from 2014 to 2016, and then they doubled again over the next 4 years. This graph shows in 2021, this looks at 29 states and the District of Columbia, that the overdose death rates in the District of Columbia had the very highest, followed very close to the state of West Virginia and the rest of the other 28 states. This graph here looks at the demographics, racial demographics of who's dying. And so this is Black persons, and the color coding is year by year. And so we see that the overdose rates have always been substantially higher among Black persons than among white, Hispanic, and that all of the increase in overdose death rates have occurred, virtually all of it has occurred among Black residents in the district. Graph down here looks year by year what drugs are involved, and much of that overdose death rate increase has been driven by fentanyl, similar to the 4 waves. And in the district, fentanyl is often combined with stimulants. And the last part was looking ward by ward. So the district is broken down into 8 wards. All the deaths concentrated wards 8, ward 7, lesser extent parts of wards 5 and parts of ward 6. So for those of you who don't know the map of the district, here's the wards 8, 7, parts of 6, and 5. And what you see in the dark blue is these are all, Black, non-Hispanic majority. In these areas, actually, it's 90% Black population, and then white majority populations. Where's poverty, low unemployment located? 7, 8, 5, and 6, those darker green areas, poverty rates 19%, about. Where are healthcare facilities located? Not in those wards. And then when you look, you could pick out almost any disease, chronic disease or acute disease, and look at the mortality rates. This is shameful, but these are the infant mortality rates by ward, 14.9 per 1,000 live births. This is absolutely shameful. But, back to closer to where the rest of the country is in the other areas. When we looked at COVID deaths, they're all constant. So these are syndemics of where they occur. So I sit on the Opioid Fatality Review Board, and we review all the opiate deaths and some key findings of the people who are dying. They've been using heroin for a decade or more. Some have been using for 25 years or more. Quarter been using for more than 40 years. But despite those long periods of time, almost none of them had ever received medication treatment. Almost none of them had ever been treated. Our system was failing. So the district has done a lot to address the structural barriers. There's nearly universal insurance coverage in the district. It's a Medicaid expansion area. And for our undocumented people, the district runs its own healthcare plan, covers people including for medication treatment. And even for people who are in that gap between leaving incarceration and returning to the community where they're not getting Medicaid coverage, the district has a program to cover them. And copays, prior authorization requirements have been eliminated. So those delays are eliminated. We've also done a pretty good job of training up buprenorphine providers. It's got among the highest number of buprenorphine waiver providers per capita in the United States. And the federally qualified healthcare centers have all adopted buprenorphine medication treatment. Nevertheless, despite addressing those structural barriers, the district ranks 32nd in the nation, buprenorphine prescribing rates. And as you saw, very few people who are dying of overdose have ever received the treatment. So there's more at work here. Having reduced some of the structural barriers, there's more at work. Oh, and transportation, there's free transportation to medication treatments. There's a system that's set up that people can take advantage of. So I came in, the timing for me was great. I was a new person in town. I didn't know the city. And the very first thing that we started doing is working with community organizations and agencies to educate me and to learn. And with some medical students, one of my faculty members, people started off, we created a community asset map in those areas, wards 7 and 8. We use that to identify and meet with community leaders, faith leaders, persons with lived experience, the federally qualified health center providers, health councils, all of that. We formed a terrific community advisory board to help direct and develop the programs. And that community advisory board has really co-led the research and program development ever since. This is what the asset map looked like. And, there are very few healthcare organizations in wards 7 and 8, but there are a fair number of community-based organizations, faith-based organizations, sports and recreation centers. There are other opportunities to be able to reach people, and there are resources there. We started meeting with the community advisory board, and here's some of the things that we heard loud and clear. So I came in, remember, I had a grant. My grant was, as most grants are, siloed. It was coming out of opioid response money. So we're going to look at what are we going to do with the opioid epidemic and in these problem areas. The community advisory board said, well, first of all, these areas, these are traditional, wonderful communities. We've got a lot of strengths. And whatever you do, you're coming in here, you're going to work with us, build on the strengths, and don't focus only on the problems. Second, which is really powerful, is what's this sudden interest in opioids? And all the funding, now all the money comes in and people are shifting to view the problems as medical. Instead of sending people to jail, why now? Why is it only when white people are dying? Does a change happen? Do the people in charge of funding and policies and providers and priorities, and do the researchers, me, or treatment providers, me, really care about us? And focus on treatment and recovery. Don't focus only on medications. There's great distrust about medications. That's just another way for pharmaceutical companies to make money off of us. Focus on drug addiction generally. Don't focus only on opioids. Focus on all the other substances. Remember, we've got a lot of issues with substances. And don't focus only on drugs. Focus on trauma. Focus on depression. Focus on some of the housing disparities, economic disparities. With the Community Advisory Board, we also set out and engaged in formative research, so qualitative research, did focus groups and interviews and shadowed organizations. We conducted interviews or focus groups with persons with lived experience, community leaders, healthcare workers in the federally qualified health centers, remember, that are providing buprenorphine. There's some overlap. A lot of the community leaders, some of the healthcare workers had lived experience. We did the usual audio taped and transcribed the interviews. We developed the interviews in collaboration with the Community Advisory Board. So it started with, tell me about the community. Tell me about what's good and what you like. Tell me what problems you're experiencing. How have opioids, other substances affected the community? What do you tell me about somebody with opiate use disorder? Tell me what your understanding is about interventions or treatments. What makes it harder or easier for somebody to get and stay in treatment? And what do you think we could do to make it better? So across the interviewee, these different categories, I think of it as sort of four main themes emerged quite powerfully. One, stigmatizing views about persons with opiate use disorder, incredibly prevalent, even among the community leaders and healthcare workers, and they keep people out of treatment. And I'll show you some of how that works, at least from the reports. Second, this was a surprise to me, was that there were really strong negative views about medication treatments. It wasn't we don't know about it, we don't want it, especially methadone, and still fairly negative views about buprenorphine. And third, there was their own sense of hopelessness. You can't do anything. And I don't know how to do anything to try to help somebody with a disorder. And there's nothing that can be done to get somebody into treatment. And the last, the hopeful, was if anybody is going to do it, it's going to need to be based out of the social networks, the trusted people in the community. So just give you some examples of the types of comments that we heard and people talked about. As a healthcare worker, but somebody with opiate use disorder, they're entitled. They just kind of want what they want when they want it. A medical assistant, they're very sneaky. They play with the system. They play with the Suboxone system. If you're not going to take the program serious, then you should get out. A community leader, I mean, they act like zombies. It's an eyesore. And a medical provider, I don't trust them. There's too much potential danger for patients having their prescription in their hand, buprenorphine. I don't want any with my name, any questions with my name on that prescription. As a peer outreach worker put it, if you're always putting them down, they're going to feel like, hey, this is all I'm worth. All I'm going to do is get high. Or I got treated real bad in treatment, put me down, made me feel bad about myself. You know, a lot of times people are embarrassed about being in a situation. You're going to be afraid that people are going to judge you. We hide it. You know, if it's their child, their cousin, they want them to get the help, but they don't want anybody to see it because the stigma attached to it. And then people have talked about, you know, what the alternative is, the roles that we can play, healthcare providers, others. My doctor had a positive impact. Although I failed him over and over, he kept his eye on me, never let me go, and his impact was the greatest of all. Or a counselor that believed in me, motivated me, made me want to stay clean. So what about the negative views about medication treatments? And again, across all levels of the community that we met with, it's just giving one drug for another. This is with a recovery coach, so somebody who does outreach. So if our outreach workers are saying, don't go into medication treatment, it's just giving one drug for another and keeping them high, and they'll just go back to using. Family members think they ain't got no teeth in their mouth off the methadone. Their bones cannot function. They become dead. One community leader said it's a crutch in the way that prevents us from really tapping into strength as a people. One drug going to another. And again, even in the medical staff and the clinics providing medication treatments, it's not universal. You know, so clearly many of the staff were positive. But if you come across the person who greets you at the front desk or the medical assistant or a clinician or a nurse, it's bad. So one nurse said, it's like with methadone. You trade one high for the next. Now they're hooked on methadone. You want them to live a normal life, not addicted to anything. Or medical assistant, sometimes the patients, they'll just get it to sell it. And then even with a buprenorphine provider who was very positive about buprenorphine, Suboxone's great. It's really difficult for people to have a sustained remission without Suboxone. I don't like methadone at all. I have yet to encounter to seem like somebody who's awake or thriving on methadone. It puts a damper on people, their personalities. Like I have the same people do really well on Suboxone. So we are not leveraging what we could be to educate and get people into treatment. Now, some of that is earned, unfortunately, by where we've located methadone programs and the ways in which programs have been put into the most segregated communities and are often overpopulated. So a number of people were talking about it's because of the volume of dope fiends all over the area. All kinds of stuff is going on. It's people making transactions. It's a mess. You see a methadone clinic. You see all these people standing around. They're always busy because they want that high. That's my outlook on it. The teacher who's talked about a program that she passes on her way to work every day. I know all these people are high and they're clearly on something. Look at them. I'm like, oh my God, I don't want that in my community. But how do we fix the people? It seems good that you have it doesn't seem good that you have all these people addicted to something in the same place. And then the nihilism that nothing's going to work. Treatment's not going to work. People aren't ready for it. They're not going to take it. And it's if you've got a family member that's an addict, you're like, dang, I'm not even on the drug. I'm riddled with anxiety every day from what they're doing. Like every time I hear gunshots or anything, I hope he's okay. Doesn't know what to do. And there's nobody who's helping us figure out what to done and can be done. And so people interviewees describe numbing that occurs when they see people addicted. You just don't want to listen. You don't know what to do. You don't want to listen. You don't pay attention. It's like, watching a car accident. And then she went on in that interview about her cousin. More could have been done. I'm not saying no one cared as far as mother, father. It's sad for his children. I believe in my heart, I believe that had they had support services, that this could have been negated. He died alone in a hotel room. So people are hopeless but desperate, figuring out something. I probably won't go through all of these, but people would remember in some of the interviews who they hadn't been thinking about and how they had overlooked. All of a sudden, the end of this interview, I forgot this. Start a whole another conversation. My neighbor across the street, she was addicted, and she crushed up her pills and gave them to her baby, and her baby died. And she did mention something, but nobody did anything. And another one, she remembers another overdose deaths. And then she made the point, she said, we got this person down the street who has Alzheimer's, wanders around, and the whole neighborhood watches out for him when they see him. They know what to do. They bring him back to the house. We're not doing that for people with addictions. And that really leads into, the importance of a network of people to be able to engage somebody into treatment. And how people have make those interventions. Okay, so let me end by talking a little bit about the projects that we've been working on and the model that we've been developing and piloting and about to expand. And this is just the slide to, if we're wondering what happens, how does methadone get a bad name? Think about what goes into the news about programs or what people see. And I think the top right is Boston program. Okay, so with our community advisory board, based on those formative evaluation findings, they came up with the idea, look, community is the cure. We need to build on and embed or programs in existing community institutions. Don't create big, large programs, and don't isolate, segregate, or, people. Figure out who the credible messengers are and train them so that they can, and have them then develop some of the anti-stigma campaigns so they can learn by doing, and then provide medication treatments on-site in non-medical community organizations. So it's an extension of, first we had it just the narcotic treatment programs, and then we bring it into a variety of primary care and medical settings. And then can we do it in a church, in a faith-based organization, and try to develop some peer-led network interventions to do outreach, engagement, educate people, sort of make use of what we learned under HIV AIDS epidemic to get people into treatment better. So the model that we piloted is we provided buprenorphine treatment on site via telemedicine in a faith-based non-medical community center called the DC Dream Center, located in Ward 7. It's a wonderful place. They run after-school programs and some job training programs. They've got a basketball court, a little recording studio, mainly run by volunteers. They started and they said, we do whatever the neighborhood needs us to do, the community needs us to do. They started by collecting garbage because people said there's garbage all over. How do we help? So they've developed the trust. We hired a peer recovery specialist. This was somebody who was in recovery, had been volunteering at the Dream Center, who does the outreach, educates community about treatment, recruits people with opiate use disorder into treatment. People come into the community center, they're going to be warmly welcomed. We can pretty much guarantee that. And we then train that peer and a community health worker to provide some basic behavioral counseling. They're not trained in counseling, but they're trained in what buprenorphine is, how it works, how to take it, how to make sure you come back to your next appointment, very step-by-step, immediate goal focused. And so focuses on what the patient needs to know, what the patient needs to do to succeed in recovery. And then via telemedicine, we link them to our clinic and prescribe the buprenorphine, which we were able to do as COVID hit. So there were problems with COVID, but it opened up that opportunity. And we ran a small pilot. First set of patients we really used to just work out the logistics. In the last 11 or 12, we've continued to do it. Looked at how long they stayed in treatment. Not bad, about 10 weeks out of the 12 that we had promised them, and then they came over for continuing treatment. They attended a fair number of the recovery guiding sessions, and they were mainly taking the buprenorphine. So there's a promising signal. We did a lot of work on revising, developing that recovery guiding manual during that period, and we're now starting this study to really scale it up and to see how well it works in doing it, as said, in Miami, Chicago, and launch some additional sites in Washington, D.C. So I think we know some of the answers of what will get more people into treatment. If we can reduce structural barriers, that's going to be helpful. And then we need to address create barrier-free, judgment-free, community-based, community-supported, evidence-based treatments. It's got to be conveniently located, welcoming, supported staff, and develop networks of outreach and really develop robust anti-stigma campaigns and education campaigns to help people understand the benefits of this treatment. So this picture of Howard University Hospital, and that's not where the treatment occurs, and the DC Dream Center and the Southeast White House, which is an adjacent building where they had started, Pennsylvania Avenue Baptist Church, which we had also partnered with, and here's our outreach worker in the basement area where our offices were set up. question came up is how is Howard University perceived in the community? I initially thought we should go in by stealth because I wasn't sure whether people would want to know that this was affiliated with a university, Howard University. And the people of the Dream Center said, oh no, that gives it legitimacy. People respect it. They don't always love it, but they respect it. And they want this partnership. So it's partnered and focused this way. That's one of the community health workers and the outreach worker doing some of the outreach and their education work. And we worked, the poster on the left was developed by the NIH HEAL initiative to begin to destigmatize buprenorphine and create different faces for it. And we worked with the district to develop a ad campaign and poster campaign and some video campaign in the district of this time it's different. And, there are different medications available. So thank you. This is the team of, cast of characters. It really is sort of a community effort. That's a picture of our current team, goes across Chicago, Miami, Washington, D.C., and my logos. So thank you all very much.
Questions? I have some online. We don't have any in the room. All right. Many of us fear that commitment via Section 35, which is Massachusetts' statute allowing commitment for substance use, that's a commitment via this Section 35 for OUD is dangerous and may increase mortality via imposition of extended abstinence, which we know is dangerous. What is your opinion of the commitment laws in the case of OUD, and do you know of any good evidence about?
So I don't know enough about the law here to know what people are committed to. And are they committed to ambulatory, if it's opiate use disorder, are they committed to ambulatory treatment with medications? Are they committed to residential, or what are, Dr.
So it is inpatient treatment that is residential, usually locked facilities, and they, I would say all of them offer MOUD, all modalities.
But they're locked up, or they're in a residential program.
Yes.
Look, I think that we've done a disservice by the focus on locking people up and incarcerating them, and then residential programs, even good ones, that have people mandated there can feel like prisons. And that can create environments that are counterproductive. So I think there's a downside to that approach that we need to look at. And need to look at what are the other ways, what else have we done for an individual and in a community to engage somebody in treatment. And, again, I assume that some of these are people who are, well, I don't want to make too many assumptions. That's the downside. I can't comment on how effective they are. If they put them, I can comment because the evidence is compelling. If they leave a residential program and they're not on medication treatment, you have done them a grave disservice. You have increased by a factor of 6 or 8 their risk of dying within the next several months. So that's the clearest thing. If they manage to shift and they say, boy, thank you for putting me in here, and I now have my life beginning to get together, and I want to stay on treatment, and I want to stay on this treatment. In particular, you give them some long-acting injectable treatments, you're probably going to have a beneficial impact.
Did have a question. So I more experience, I think, working with the Hispanic population, both in New Haven and also here. But it seems that initiation patterns of opioids seem to be very different compared to particularly to white people, with higher likelihood of start with synthetic opioids, higher likelihood to start IV instead of other modalities. And so the progression of the illness is faster. And it seems like we're talking about treatment, but it also feels like there's not enough that is being done in terms of targeted messaging for harm reduction, and really educating about safe use. The goal has been into entering treatment, and missing that part that would just keep them alive, really.
Yeah, no, I completely agree that we it's a multi-pronged approach, and the prevention and the messaging and the Narcan availability, and potentially for people who don't think they're using opiates, some of the fentanyl test strips may be useful. And the initiation patterns are very different in different groups and within different cities. So we're seeing, unfortunately, in Central American immigrant youth, a spike in overdose deaths, and people are initiating in sort of high school groups and where they are, and they're smoking the fentanyl predominantly. It's not injecting, but generally people start and use the way the people around them are starting and using. And so those patterns will differ, but we know that we can affect those patterns if we can work within the networks. And so we know that if you can get somebody from inside the network to begin to shift, that person has credibility and says, if it's a harm reduction message, you could still get high, but you could do it more safely this way. That will make an impact.
One last question from online. Physician bias, whether conscious or unconscious, can also play a huge role in treatment retention in MAT when it comes to people of color. How can we as providers fix how we treat patients with addiction?
Well, the first thing is becoming aware of where your biases are and being open to it. So that's important. Whether some of the implicit bias tests can be helpful for people, or that's useful. I'm at an institution that's committed to training more Black physicians and more Black healthcare providers, and that's critical because even studies that even well-intended, very nice white people like me don't necessarily have the same impact when we give the same message on a Black person as a Black physician. And it's not, because I'm bad or I didn't do the right thing, but there's a trust and an interaction that's different. There's some, lovely studies in healthcare that, document that people are more likely to follow through with the recommendation to get a flu shot if it's a Black provider than a white provider. So you can address the bias, you can be careful, you try to educate. My own sense is some of the best ways of dealing with stigma are more exposure to people. So if you see people who are in recovery, it really can help shift the roles, and that some of those FQHCs, we've tried to help them organize groups of their patients who are in recovery, who can then talk to the healthcare providers who may mainly focus on the one loud, obstreperous, person who's causing the trouble, and then they say they're all like that. And to counter with, here's how this medication's working with me, that's often quite compelling for people.
All right, great. Well, listen, it's 1:00. Thank you very much.
Thank you.